Okay, thank you for the video, and thanks all of you to be here with our webinar. As you can see, our product is very fast. If you are practiced, and the physicians and the doctors can process the whole software within 3 minutes. 3 minutes is enough, and the calculation process is 30 seconds at most. So it's very fast and very easy. If we combine the CFFR, CAMR, and CDPR together, we can do more assessment and have more functions. And if you have any questions, you're welcome to communicate with Professor Huo. Professor Huo is the founder of our company, and he's the CTO of our company. He designed the CFFR system, and he's almost the idol of everyone in our company. So do you have any questions? You are welcome to ask. Professor Huo will answer it one by one. So any questions? Okay. So, Professor, I have one question. I know CAFFR, CADPR, and CAIMR are both very important. How can we combine all these parameters to provide the doctors a tool to assess the ischemia or the microvascular disease? How can we combine them to do the diagnosis approach?
Because how can normally we should first using the CAIMR to determine the patient has a microvascular disease or not, and then we can use the CAFFR to determine the FFR value and to give the more accurate estimation of the FFR value. I think that should be very useful. A combination of the CAFFR and the CAIMR can significantly improve the physiologically assessment.
Okay. Okay, thank you, Professor. And the one attendee have asked, do you think, so Jericho, yeah, I'm sorry, I can't pronounce it well. So do you think that CFFR will replace classic FFR from clinical practice?
Sure. Because we have the retrospective clinical studies with Hong Kong. Fendi knows it.
Yeah.
You can explain it.
Oh.
You can explain it. I think you involved in this project.
Yes, I have followed the Hong Kong, the Hong Kong project from the very beginning, and first we have the clinical trial called Flash Angel 1. Flash FFR, right? So the first clinical trial of our company, we have 328 vessels to compare CFFR with wire-based FFR. The accuracy is very high. It's 95%. It's 96%. So the accuracy with wire-based FFR is very high, and we have a very good correlation with FFR, and it's very fast in the manipulation process, and it's very safe because we don't use wire and we don't use Edison. And I think we can totally replace FFR in the future.
No. Let me explain it.
Okay.
You don't know what I want to say. Because the doctor concerned, the FFR is that useful for the patient. It's not we only compared with wire-based FFR. So we have get a retrospective study. Totally, we have close 2,000 patients. These 2,000 patients, they have the PCI, or they went to the CAS lab in 2014, 2015, 2016. And then they have the clinical results as a 2017, 2018, 2019, and 2020. And using our CAFFR, we they give the doctors in Hong Kong give us the angiogram, and then we calculate the CAFFR value and then send back the CAFFR value to Hong Kong. They found that based on our CAFFR, uh, they can totally repeat the film clinical trial, like the film 1, film 2, even film 3. They found the films based on the CAFFR. We can estimate the myocardial death even better than the very based FFR. So I'm very sure about it. We will totally replace the classic FFR from the clinical practice. Also, we will carry out our Flash 2 clinical trials. In this Flash 2 clinical trials, we will estimate the 1 year MACE, uh, 1 year MACE rate based on the CAFFR and the VAR-based FFR. We will estimate which one is better, but based on our retrospective study, I believe our CAFFR will totally replace the VAR-based FFR after we finish our Flash 2 clinical trial. Thank you.
Okay, thank you, Professor. Okay, I know the answer. And as a next question, I can answer it. Can I to compensate my mistake? Jessica asked, can you calculate the parameters simultaneously? If
Sure.
yes, yeah. So in our Hong Kong project, we can calculate CAFFR, CADPR, CAIMR simultaneously, and we can write out all these three parameters at the same time. And the advantage to have all these values measured, I think Professor has already answered it. So
We can simultaneously estimate the microvascular disease and also the myocardial ischemia induced by the epicardial stenosis. We know our stenting is only for the epicardial stenosis, but how can you treat the microvascular disease? Microvascular disease is very important. If you know the microvascular disease, you can use the CAFFR to estimate the stenotic effect even better.
yes.
Thank you.
Okay. Okay, thank you. So another question is, Jethro, okay, sorry, ask, is it possible to apply this approach to peripheral vessels as well?
Peripheral vessels, I'm not very sure. We can calculate, but the doctor can use it or not because there is a lot of debates about the physiological assessment in the peripheral vessels. But we can try. That need more time. We hope we can use the physiological assessment. We can find the very good cutoff values for the CAFFR, CAMR, and the CADPR for the peripheral vessels, especially for the carotid arteries and the iliac arteries. I'm not very sure about it. That need a long that needs a how can I say long-term clinical trials to validate.
Okay, thank you. So can we calculate IMR? Yes, I can answer the question, right? But we calculate CAIMR, right, Professor? See, it's the coronary angiography based IMR. We use the angiographies and the TMIF Timmy method to calculate CAIMR, and we have the same cutoff like
Yeah,
with
we can
IMR.
calculate that. We can calculate the IMR.
Yes.
But we call it the CAIMR. We got good correlations between the CAIMR and IMR. This IMR is variable-based IMR. But you know, if you want to measure the IMR, it's very difficult. You need to inject saline at least 3 times. If the doctor is not familiar with variable-based IMR, the doctor needs inject the saline maybe 6 or 8 times. But our CAIMR is very stable. You can get it immediately and only one result.
Okay, thank you, Professor. And with new questions, let me check. So, Professor, do you know the price of CFFR in the worldwide? Like,
Yeah, for this question, I think we can answer by after the webinar. No problem. Thank you.
okay, okay.
Hi, Professor. I'd like to ask a question, if you don't mind. My name is Chandan.
Please.
It's Chandan from Malaysia. Thank you very
Chandan.
much for the wonderful presentation.
Oh, yeah, from the island. Is that from island part?
Correct, from Sarawak. That's right.
Yeah. Sarawak.
Thank you for having me on this presentation. I'd like to make an inquiry on the use of CAFFR in atrial fibrillation. As we know, the machine, the console, uses an average of the aortic blood pressure to calculate the flow rate, right? It uses 5 cycles. But in patients with atrial fibrillation, the blood pressure tends to be erratic. So there might be one beat where the blood pressure is high and the blood pressure is low. Have you found that this affects the CAFFR value?
I'm sorry, we didn't try the atrial fibrillation.
Right.
Because atrial fibrillations, in that case, you first need to recover the patient. We didn't try this part.
Right. And secondly is in the use of this technology in patients with myocardial infarction. So in the FLASH FFR trial, the patients with acute myocardial infarction were not recruited. But I'm sure in your extensive research, you must have had patients with recent MI. Do you find this technology is useful in this group of patients?
CAFFR cannot be used for the acute myocardial infarction. You have to use a CAIMR. CAIMR is much better. But CAFFR may be good, but I'm not very sure about it. For example, if you have the previous myocardial infarction, and then you have another myocardial infarction, like the acute myocardial infarction, I'm not very sure about it. But I can answer your question. The CAMR should be very good for this kind of situation.
Okay, thank you very much.
Thank you.
Thank you. So another question from Michael. In opinion, being less invasive, will CFFR increase the number of FFR tests in all case lives? So, is there?
Sure.
Yeah.
I think so. In China, we will improve it significantly, but now we have the COVID part. We cannot go to the Europe and USA. We hope put our machine to Europe and USA. If you have time, you can try it, and you let the doctors to evaluate. Let doctors try our devices. But in the current situation, we can only discuss from the webinar.
Okay. Okay, thank you, Professor. And another question from Jessica. Is there any affection on CAIMR by epicardial stenosis severity?
Yes, but we have already included. We consider about the effect of the epicardial stenosis severity on the CAIMR.
Okay. The last question. Do you plan to study non-corporate ligand estimation in a STEMI setting?
We can do it. We have already estimated. We included in our FLASH 2 clinical trials.
Okay, thank you. So any other questions, you can talk to Professor Huo face to face. I think it's more convenient, and we can know each other better.
Professor, can I ask a question again, if you don't mind?
Sure.
Do you have experience in using CAFFR in patients with reduced LV ejection fraction? Or is there a
No.
cutoff that you would suggest not to use it?
Reduce the LV ejection fraction. No, that's I'm not sure about it, because if they have the myocardial, if they have the heart failure, FFR is useful or not, I'm not very sure. But I think maybe
Right.
CAMR will be useful. We need to use it to estimate, because I believe CAMR is very, if the CAMR is very high, it's very easier to induce heart failure with preserved ejection fraction or the reduced ejection fraction. I'm not very
Right.
sure about it. That need more clinical studies.
Okay, thank you.
Okay, so any other questions? Okay.
Right, Professor.
Hello, Bob. Do you have any questions?
Yeah, can you hear me?
Yeah.
Okay, I have a small question that I saw in the presentation. When we calculate the CIMR, why should we set the L is equal to 7.5 centimeter?
Oh, because if you put L is if you didn't consider more L, that's not good, because when we calculate the IMR means microvascular resistant in unit volume. You need to put it more distal to get the microvascular resistant in unit volume. I emphasize here is in the unit volume of the myocardium. It's not the total part, because if you put it to the more proximal position, the IMR value should be very large. We have to put it to very distal, close to the maybe 7.5 centimeter. That will be the best position.
Okay, clear. Thanks very much for.
Okay. So
Professor, can I ask another question? What do you think the performance of CAFFR in left main stem diseases?
Oh, left main. I'm not sure about it, because FFR, is that useful for the left main or not? I'm not very sure about it.
Right.
Yeah,
Right.
but if you are interested, we can open a project to test it.
No, I mean, I'm asking because we all the questions I ask are very common clinical situations we get placed in. So I want to know which cases I should avoid using the CAFFR for fear of a false reading or a false reassurance. That's all.
I think CAFFR may be useful, but we still need to clinical trials to validate.
Right.
Thank you.
Okay, thank you.
Okay, thank you. Now we will send you a questionnaire link, and would you please kindly fill in the questionnaire and give us some feedbacks in order to we give you better and better webinars. So Nick, can you send us the webinar, the questionnaire, please? Okay, so thank you, everyone. Can you give us 1 minute to answer the questionnaire link? Thank you, everyone. If you have any questions, you can also don't hesitate to ask. Professor Huo is here, and I think he knows everything. We will need 5 minutes, so when it comes to 5 minutes, we will close our questionnaire. So thank you.
Bye bye. Nice to see you.
Thank you, Dollars. Thank you. Bye bye.
Bye bye. Thank you.
See you.
Bye-bye.
Bye bye.
Bye-bye.
Okay, thank you for your time and thank
Bye-bye.
you. Thank you.
Bye-bye.
Thank
Bye.
you
Thank
all.
you, everyone.
Thank you.
Thank you for your time. If you have any questions, you can contact us via our website or any other social media platform. Thank you for your time. Thank you for participation.
Thank you, everyone.
Bye bye.
Thank you, everyone. Thank you. Thank you for your time and join us. Thank you.
So wish you and your family safe and sound.